So the title of this talk is What Was Old is New, Treating Trauma with Plant Medicine. Now, actually, just as a disclaimer, most of what I'm going to be talking about is actually not specifically from plants. So I'll be talking about MDMA-assisted therapy, I'll be talking about psilocybin, but I will get to a little bit of the true plant medicine towards the end of the presentation. So for those who don't know, the term plant medicine is usually synonymous with some kind of psychedelic compound. So what is that term? What does it mean? So psychedelic is essentially a class of compounds that profoundly alters, expands, or intensifies one state of conscious awareness or sensory perceptions. That term was actually coined by a psychiatrist back in the 60s named Humphrey Osmond. He took the two Greek words, psyche and delos, meaning mind and manifest, and then conjoined them together to come up with the term mind manifesting, essentially to describe the effects of psychedelics. And that's a pretty apt term, given that they do manifest properties of the mind that are not usually present for most people. We know from a whole lot of anthropological study that these medicines have been used for hundreds, if not thousands of years by indigenous cultures around the world, including mushroom ceremonies in Mexico, as well as ayahuasca ceremonies in the Amazon rainforest. We have archaeological evidence suggesting that the use of the San Pedro cactus dates back to sometime in the basically 900 to 200 BC. Sorry, the slide is cut off there. Basically about 1,000 years ago in a culture called the Chavin culture that used this as part of their traditional spiritual ceremonies. We also have evidence that the Mayans, for example, used psilocybin mushrooms as well as part of their spiritual and religious ceremonies, as you can see here from some of the archaeological evidence. So a long history of use by indigenous cultures, sort of just beginning now to get integrated back into sort of the Western approach to treatment of mental health conditions. So what are some common psychedelics and pathogens? And I'll talk a little bit about the differences between those. So I've kind of broken these up into natural and synthetic. So on the natural end, probably the most popular, most well-known would be psilocybin, which is basically a chemical that's found in a genus of mushrooms that grows pretty much everywhere except Antarctica. So you can find them pretty much all around the world. The active chemical in that is actually psilocin. So psilocybin is what we call a prodrug, meaning that when you ingest it, it gets broken down or dephosphorylated into psilocin, which is actually the active compound that produces the psychoactive effects. We also have mescaline, which is most commonly found in various cacti that grow around the world, most famously the peyote cactus used by the Native American church as part of their traditional ceremonies, as well as the San Pedro cactus that I mentioned earlier, which grows in Central and South America. And then finally, dimethyltryptamine, or DMT, is another very famous popular psychedelic compound, most commonly found in the ayahuasca brew, which is indigenous to the Amazon rainforest. It's a combination of various plants, but the DMT itself usually comes from that plant that's pictured there. It's called the Psychotria viridis plant. It's basically like a relative of the coffee plant. On the synthetic side, everybody's probably heard of LSD. Typically comes in the form of colorful blotter papers. You only need very small amounts in order to provoke a psychedelic or psychoactive effect, and very popular back in the 60s in particular. And then on the empathogen side, we have a compound called MDMA, famously known as ecstasy, which essentially is usually sometimes found in this pure white powder form called pure Molly, more commonly found in the form of these colorful tablets where it's usually mixed with other compounds and taken at raves for recreational purposes. So we've got a whole bunch of various psychedelic compounds that are in recreational as well as indigenous and cultural use, and some of these are also being developed for mental health purposes. So why are we even looking at psychedelics for mental health purposes? And I think the main reason is that we have a real dire need for better forms of mental health treatment. So take, for example, the case of major depression, where studies have shown if you treat people with an antidepressant, about 2/3 of them will not show an adequate therapeutic response to their first antidepressant treatment. And then of those 2/3 that don't respond initially, another 1/3 will go on to not reach remission after 4 consecutive courses of antidepressant treatment. So there's a whole large number of folks out there that just aren't really adequately served by our existing pharmacological treatment approaches. Take the case of post-traumatic stress disorder as well, where the best form of treatment is actually a psychotherapy, something called trauma-focused psychotherapy. We know from our studies that about 1/2 to 3/4 of patients will not reach remission with trauma-focused psychotherapy. And then after that, there's not really a really good pharmacological treatment for PTSD in the traditional sense. So there is definitely a need for better treatments, and psychedelics in recent years, particularly when given with psychological support in controlled environments, has shown tremendous therapeutic potential, particularly for folks that have been largely treatment resistant or have not responded to our existing treatment approaches. So one way that psychedelics may be exerting such a broad array of effects across various conditions, including depression, PTSD, addictive disorders, as well as end-of-life related anxiety and depression, is that I'm thinking about it as sort of a novel paradigm shift in the way we think about treating mental illness. So the way I would couch our existing approaches would be something like a precision approach, for example, like an SSRI antidepressant, where we think it's having a very specific effect on a very specific site of action in the brain that over time and with repeated administration results in some sort of therapeutic effect. So these treatments are typically given chronically, meaning like once a day or once a week in the form of psychotherapy. They tend to take a while to work, several months typically, and they tend to be just a few sites of action that we try to isolate with these treatment approaches. So to use an analogy, if we're thinking of mental illness as like a rock wall, for example, that needs to be broken down, these sorts of precision approaches are akin to using a rock hammer to try to get this wall broken down. So it's very precise, it's pretty small. You try to chip away at specific sites in the wall that you think are weaknesses in order to be able to exert that therapeutic benefit. On the other hand, psychedelics are probably more like what I would consider an impact approach. So another approach that might be similar to this is the very old school electroconvulsive therapy. So this is electroshock therapy for people that have heard of that before or seen One Flew Over the Cuckoo's Nest. It actually sounds pretty barbaric, but it's actually one of the most effective treatments in psychiatry. And the reason I think they're similar is that I think they both exert very profound effects on the brain. They're only administered acutely, meaning usually once or a few times. And they tend to be very rapid acting too in their therapeutic benefit. So unlike the traditional antidepressants and psychotherapies that we use, psychedelics and other forms of impact treatments, we might say like ECT, tend to have these very profound effects. They tend to act rapidly and they tend to exert basically a broad array of actions across the brain. So to go back to our rock wall analogy, instead of using a rock hammer, this would be more like taking a sledgehammer to that wall. So let's talk a little bit now about the pharmacology. So what happens after one ingests a psychedelic? This includes, for classical psychedelics, the typical ones like psilocybin, DMT, LSD, and mescaline. We know from existing studies that they exert their effects, their subjective effects, primarily through a receptor in the brain called the serotonin 2A receptor. We know this because if you block that receptor with another drug, you will block the onset of a psychedelic experience. In addition, we know from sort of non-invasive brain imaging studies that the degree of subjective experience that people have with a psychedelic compound correlates with the degree to which the compound is binding to their serotonin 2A receptor. So pretty good evidence that that particular site is very important for the subjective effects. However, they're far from specific to that site of action. So psychedelics we know bind to a whole bunch of different serotonin receptors throughout the brain, some of which are listed there. And then some psychedelics also bind to other receptor sites in other neurotransmitter systems in the brain. So they're definitely having a broad array of effects, but we know for sure that that 2A receptor seems to be particularly important. MDMA, on the other hand, has a different sort of mechanism of action. So MDMA stands for methylene dioxymethamphetamine. So it is actually a derivative of the methamphetamine compound, but very different in its safety profile and its subjective effects. It was initially discovered back in the 40s and then was actually first utilized as a psychotherapy adjunct drug before it ever became known as a recreational drug or a drug of abuse. It's known to enhance feelings of interpersonal closeness, communion with others, promotes feelings of safety and trust, reduces fear, and that's sort of how it's sort of become to known as an empathogen or an entactogen, meaning it promotes that degree of empathy or that degree of interpersonal connection with other people. And we also know that because its effects are different than that of classical psychedelics, where you typically will have visual hallucinations, a profound shift in one's sense of self, MDMA, on the other hand, is a little bit more like a love drug, or it gives you a sense of closeness, good feeling, and connection. It also has a different mechanism of action, so it doesn't work through the same 2A receptor approach. Instead, it actually causes the brain to release its own stores of serotonin. So similar to like an SSRI, but actually a little bit more potent, it causes a massive release of serotonin in the brain synapse. And then that serotonin release is what seems to provoke most of those subjective effects for MDMA. There's also some similar effects on the norepinephrine and dopamine systems as well, but serotonin is the primary one that we believe it works on. It also doesn't typically produce these hallucinations or these transpersonal or mystical experiences that people sometimes report with the classical psychedelics. So I'll talk a little bit now about how these are being administered in the context of modern sort of psychiatric treatments. And at the moment, all of these are research only, so they have not yet been FDA approved for the treatment of any condition, which means that you can't get it prescribed by a doctor. You'd have to enroll in a research study in order to be able to sort of experience these treatments. So the way in which it's delivered, it always begins with a prep session or one or more preparatory sessions. Typically lasts about 4 to 8 hours, can be anywhere from about 1 to 4 sessions where the person will meet with a therapist. They'll undergo informed consent, talk about the risks and benefits of the treatment approach. And then there's rapport building. The patient and therapist get to know one another. You'll typically have at least one therapist and sometimes more than one in this process. And then there's a lot of discussion about how do you manage or deal with the psychedelic experience, including some of the subjective effects, what you might expect, how to sort of navigate that experience, and what to do particularly if you start to sort of freak out or have what they call a quote-unquote bad trip. And that can usually be managed pretty effectively through grounding, breathing exercises, support from the therapist, and so that's a pretty common thing that will come up for people. Then after that, there is the dosing session, and this is where the psychedelic is administered. It usually starts in the morning because it's typically an all-day kind of procedure. It can take 6 to 8 hours on average, and the drug is given in a comfortable sort of living room-like setting or environment. So we have a dosing room at UT, for example, 2 of them actually. There's like a futon and a few chairs, some plants, some artwork. It doesn't look anything like a typical doctor's office. And the idea is to try to make it as comfortable as possible for that person undergoing the experience. Now, unlike typical therapy, participants are encouraged to lie down on the futon or the couch, don eye shades, and then they're given headphones, and there's a sort of pre-selected music playlist that's provided for them as they go through the experience. So it's a very much a sort of a different approach. The idea is to try to get the person to focus on their internal experience as the effects of the psychedelic sort of take hold. And really, there's not that much usually interpersonal interaction, except for perhaps with MDMA, where it does tend to be more pro-social. The therapists are kind of there in the background, waiting patiently, ready to support the participant in whatever way they may need. But it's typically more of a hands-off sort of allow the person to journey and be there if needed kind of approach. Any difficult experiences that might come up in that process, the therapist will usually help that participant through using supportive approaches, reassurance, sometimes literal hand-holding, and that sort of thing. And then after the dosing session, we have what's called the integration sessions or the debriefing, depending on different terms for the same thing. And it's usually at least one session, can be more. Usually starts the day after dosing, and you typically want to see that person back immediately afterwards to make sure that they're doing okay, assess what we call adverse events or side effects. Do you have any headaches? Did you have trouble sleeping, et cetera? And it's really about safety and making sure that person is doing all right after their psychedelic experience. And usually there's a discussion. The therapist will kind of help that person begin to make sense of what they experienced under the effects of the psychedelic. There's some non-judgmental active listening. There may be some interpretations discussed of the experience. And this is actually the part of the treatment that I think is the least well understood or the least well optimized at this point. Because we really don't know what we should be doing in that period of time afterwards to help that person sort of best consolidate their experience or best integrate their experience to have the most lasting therapeutic benefit. There are different ways to think about this, but in general, at the moment, it's all been pretty supportive therapy-oriented, just kind of helping that person sort of discuss what they went through, and then try to kind of derive some meaning from it that might allow them to move forward in their life with a new outlook or a new direction. And so this approach has been most widely utilized recently for MDMA, specifically for PTSD. So there are at least 2 phase 3 studies that have been published both in very high-tier journals, depicted there, Nature Medicine. And the results are quite promising. So there you can see is the chart of the outcomes. So basically the y-axis is PTSD symptoms, so higher means more symptoms, and then the x-axis is after 1, 2, and 3 dosing sessions. And you can see that there's a nice kind of dose-dependent drop in PTSD symptoms relative to a placebo assisted therapy condition. So people went through the same therapy, same kind of procedure, but simply took an inactive placebo instead of MDMA. This is the means, or the graph from the second phase 3 trial, and you can see they look pretty identical in regards to the effects. So very promising evidence there, a very large effect size too. And I always like to present this slide because I think it really drives home for people how effective this treatment can be. So if you look on the right quadrant, or the right bar, you might say, in each, this is the percent of folks in remission, response, or that lost their diagnosis after 1, 2, and 3 dosing sessions. So if you look at the darkest shade there, that's the percentage of the sample that was in remission, which means that you no longer have any substantial PTSD symptoms after going through this treatment. The right side is the MDMA, those are the red bars. The left side is the placebo group. And what you can see is that the remission rate in the MDMA group is about 30% after 3 sessions, which is actually a huge remission rate, especially compared to any of our existing treatment approaches. And it's about 6 times the remission rate that you see in the placebo group as well. So very, very promising evidence, which was then turned into an FDA application, what's called a new drug application. So every time you do a study and you try to develop a drug, you do your studies, you collect your data, you put it together, and then you send it to the FDA as a new drug application for them to review and potentially approve or reject, or decline to approve, I guess you might say. So the group that did this was called Lykos. They used to be called the MAPS Public Benefit Corporation. They submitted this package for FDA approval of MDMA-assisted therapy for PTSD. There was a lot of press around this. Some of you may have heard about it. And there was an advisory committee held in June of 2024. And they voted 9-2 against evidence of efficacy, as well as 10-1 against evidence for the benefits of this treatment outweighing the risks. And the reasons for that were that they did raise several key issues that I think probably went into the FDA decision that I'll get to in a moment. One was functional unblinding. What this means is that when you do a study with a drug, you try to do it double blind, meaning you try to make sure that neither the patients nor their providers know what drug that person got, whether it was the active drug or the placebo. Now, could anybody see a problem with that for MDMA? It's pretty hard, right, to take MDMA and think that you didn't get it, right? Or vice versa, get a placebo and think that you got MDMA. So they assessed blinding, and basically everybody could tell what they got, right? And so this is an ongoing issue in psychedelic research. It's a very challenging problem to solve. Another issue was that a lot of the sample, about 40%, had prior MDMA use. So this kind of amplifies the unblinding effect, right? If you've had it in the past, you sort of know what to expect, and once you feel it, you're more likely to know that you got it, right? There was also this strange thing about the role of the psychotherapy in the treatment effect. So the drug company presented this as a drug-assisted therapy combination. Now the problem is that the therapy that they used didn't have any evidence for actually being helpful in and of itself. So that sort of blows up the idea that a drug is assisting a therapy, right, to be helpful. If anything, it's probably more of a therapy assisting the drug, right? And so that, I think, was a strategic error on their part, but probably not the most key issue, but a lot of others as well that probably contributed to a negative outcome here. There were issues, too, with boundary violations. So there was a case in one of the phase 2 studies of a therapist, the therapist team essentially having an inappropriate relationship with one of the patients, right, which is a terrible thing that should never happen in any clinical study. There were some issues around follow-up data and some other issues around tracking of adverse events. So altogether, this kind of led to the FDA issuing about 2 months later a complete response letter to the drug company, basically rejecting the current package and saying we can't approve it at this time. And they requested another phase 3 study to be conducted. Now, I believe currently still, this letter's never been made public, so we don't know the exact reasons they rejected the package, but we can probably assume that some of that pertained to some of these issues that were brought up at that advisory committee meeting. And at the moment, as far as I know, the Lykos is sort of trying to engage in mediation with the FDA. There will need to be another phase 3 study, but it remains to be seen when and if that's going to happen. So at the moment, we're kind of stalled out on MDMA-assisted therapy. The other major area that's kind of gone through a well-developed, at least in the psychedelic realm, is psilocybin for depression, right? And so this is synthetic psilocybin. So this is not derived from mushrooms. This is essentially synthesized in a laboratory for purity and standardization. It's basically, subjectively though, very similar to taking psilocybin mushrooms, at least according to most. Some might disagree. These are the two largest studies that have been published to date. One of them was looking at treatment-resistant depression. Another one was looking at psilocybin for just regular depression. And both had positive findings. So here's the results from the treatment-resistant depression study. They did a dose comparison. So they looked at 25 milligrams, 10 milligrams, and 1 milligram of psilocybin. And they saw this nice dose-response relationship where the largest drop in symptoms was in the 25 milligram group, followed by the 10, followed by the 1. So very, very sort of good evidence for a dose-response relationship. The other study in regular depression just looked at psilocybin versus a placebo, and likewise saw some very significant benefits of psilocybin over placebo. So that line of research is still ongoing, and we actually have a phase 3 study running now at UT as well, and that will probably be at least another couple years before psilocybin is able to be rolled into a new drug application to the FDA. A couple of the true plant medicines that I'll mention before I kind of wrap up here. There's been a lot of hype and interest around ibogaine. Ibogaine is an atypical psychedelic. It actually comes from an African tree called the Tabernathiboga plant. It's found in the roots. It's a small shrub-like plant native to Africa. And it's used indigenously there by the Bwiti and as part of their religious ceremonies. And when it's administered for therapeutic purposes, it's typically derived from a related plant called the Voacanga africana plant that also produces this, and then it's synthesized for use as a synthetic compound. So this compound is very interesting because it has the unique property of being able to interrupt opioid withdrawal. And so it sort of became popularized back in the day because people would use this compound for people that were addicted to opiates. They would go into withdrawals, they'd administer ibogaine, their withdrawal symptoms would cease, and they have this long 12 to 36 hour psychedelic experience where they would confront their demons, so to speak, and gain insight about why am I addicted to opiates, how did I get here, and it really had this sort of profound like 1-2 punch for helping them to recover from that. As I mentioned, the effects are very, very long, 12 to 36 hours, and so this is going to be a very challenging treatment to administer in a clinical setting for that reason, right? There was one study recently published with this looking at ibogaine treatment for special operations forces veterans with traumatic brain injuries and post-traumatic stress disorder. Showed open label, so like a single sample, not blinded in any way, so very preliminary data, but did show very promising evidence for benefits of ibogaine in treating symptoms of PTSD, other mental health problems, and actually improving cognitive function in those with traumatic brain injury. So very promising compound. It's being developed actually now for use in clinical trials in the US. And we do actually have an ibogaine study going as well. It's observational where we're following folks that go to and from Mexico to undergo this treatment where it's legal. And then finally, I'll mention ayahuasca for depression. So this is another true plant medicine, combination of at least 2 plants, one of which contains dimethyltryptamine or DMT, which is the serotonergic psychedelic. The other plant contains something called beta-carboline compounds, which essentially allow the DMT to become orally active, and they inhibit an enzyme in the gut that typically breaks it down. So somehow the native peoples stumbled upon this combination to create this powerful psychoactive brew through combining these 2 plants that if they're not combined, you wouldn't otherwise have that capability. So it's been used indigenously in South America for hundreds, if not thousands of years. And there's been at least one randomized clinical trial where they used real ayahuasca, and then they had a nice placebo condition where they created another disgusting brown, gooish compound that tasted bitter and awful, and people weren't able to distinguish the two. and actually showed that the ayahuasca did beat out that placebo version of it as well. This is going to be a difficult one to develop as a pharmaceutical because of the fact it's a plant-based and it's a combination of two plants. But I know that there are studies going with dimethyltryptamine, which is one of the active ingredients, and then there are pharmaceutical companies actually looking at that sort of synthetic combination of the beta-carbolines and DMT as well for treatment. So overall, I sort of threw a lot of information at you, so I'll go ahead and summarize. So what we know is that psilocybin and other classical psychedelics, that their main site of action is that serotonin 2A receptor, right? On the other hand, MDMA, which is that empathogenic compound, works through blocking reuptake and causing release of serotonin in the brain. So it's sort of different mechanism of action with a different set of subjective effects. There are many, many differences between psychedelic-assisted therapy and our typical approaches to treating mental health conditions, including both medications as well as traditional therapy. One is that these are typically acutely dosed, maybe 1, 2, maybe at most 3 times over a period of time, as opposed to like a daily pill that you would take. There's the controlled setting of drug administration that you undergo with a trained provider. You know, these are not things you're ever going to pick up at a pharmacy and take home, at least not for the foreseeable future. The effects are rapid, which is a real benefit, right? So normally it takes weeks to months for our treatments to help people. These, it takes hours to days. Right? People typically feel better by the next day, which is a real, a unique benefit of these compounds. The current best supported indications include psilocybin for treatment-resistant depression and MDMA for severe PTSD. And there's current, ongoing efforts towards FDA approval. It's looking like, if anything, psilocybin might get there first. In the next couple of years, we'll see. There's a new drug application that'll have to be submitted. MDMA is going to require at least one more phase 3 study before that's a possibility. Okay, and then I'm just going to throw out my contact info here for anybody who might want to reach out or have questions. We have various studies going on at the Center for Psychedelic Research and Therapy at UT. They're all can be found on that study listing page with instructions on how to sign up. So please feel free to pass them on to people that you think may benefit. Thank you for your attention. I'm happy to answer any questions.
Thank you. Great discussion. I'm glad you brought up Lykos. Just a couple comments there. One of the things I think that wasn't called out is perhaps the FDA needs to reevaluate the criteria they use to assess efficacy in this therapeutic area, right? So you called out one of the problems was the blinding, right? Seems like an obvious one. They did a good job of establishing safety, right? There were no significant adverse events, I think, reported. So I wonder if Lykos is engaging, as they seek consensus on the next trial design with the FDA, to try to get them to rethink how they're ultimately evaluating success for that next trial. And I have a part 2 so I'd ask for you to comment on that. But also, I think one of the challenges when you think about psilocybin, MDMA, and ibogaine, these are naturally occurring compounds. It's very hard to get IP protection, right? To be able to recoup the hundreds of millions of dollars of investment cost, right, that you have to get ultimately to an approval. So I wonder what the solve is for that, and if perhaps there's synthetic versions of these compounds that do represent a novel molecular entity that you could patent that are more likely to get to an approval pathway where you can get the investment you need. Thanks.
Yeah, great questions. So the first question about how do we sort of evaluate efficacy, right? And psychedelics do really raise this point because these issues of functional unblinding are not unique to psychedelic studies. They happen in other drug trials as well. It's just that they're very prominent, right, in this case. And I know one of the issues unfortunately, that Lykos went through is that there was like a changing of the guard at the FDA as well. So when they initially sort of negotiated the design for these studies, it was a different sort of leadership team there compared to the one that actually reviewed the application. And so that, in some ways I feel like the goalposts got moved on them in that process. And, it's a very pertinent question about do we need to revise our criteria around how we judge efficacy and the standards by which we sort of consider something to be valid evidence. And I think psychedelics really, really emphasize the importance of those considerations. I don't know if there's a good answer yet for whether or not that's going to happen or how it's going to happen. I do think that it is possible to try different comparator conditions that might improve blinding. And I think the typical approach the FDA has recommended, at least up until this point, is to have at least one study against an inactive placebo, which gives you a better indication of safety and what some of the safety problems might be associated with that drug that you're unlikely to see with an inactive placebo. And then have another study where you have really try to focus on blinding. And so you might have that drug versus another active compound or a lower dose of the same drug. And I think with MDMA in particular, it might be possible to use something like either amphetamine or methamphetamine as a possible comparator that could actually improve blinding. That's actually one approach that we're going to be taking in a study that we're hoping to get started in the next year or so. So a lot of stuff that could happen. Oh, and then to get to the second part of your question, shit, what was it? Oh yes, IP. Thank you. So yes, so MDMA is not it's not naturally found, but it is not patentable because it's so old. And so the approach that some companies have taken is Compass Pathways, for example, patented a crystal polymorph of psilocybin, which essentially is like how it is sort of recovered out of solution and crystallized into its final form. And so that was actually the IP that they developed around this, and then they developed some other IP as well, but that's really the main one that kind of protects their intellectual investment. And then there are other companies I know of that are doing a nonprofit or sort of like the public benefit corporation approach. USONA Institute, for example, that produces psilocybin is a nonprofit. So it is a tricky area though, because a lot of these classical compounds are not patentable in and of themselves, right? You have to sort of come up with a novel way to do that to protect your investment. I think the other option that a lot of companies are pursuing is trying to create novel analogs, for example, or novel compounds that mimic some of the effects of these classical compounds, but that do have that ability for IP protection. Thank you. Yeah, you're welcome.
Anybody else? Okay. And we'll do last question because I know you gotta roll.
Knowing that you're not a lawyer, so you can't advise, what is the current kind of landscape for Texas? Just with the change politically, there's some possibilities that are looking really promising. So what is your current awareness on where Texas is kind of headed with psychedelics?
Yeah, great question. So Texas is Texas is unique, I think, when it comes to psychedelics, in that it's classically considered a pretty conservative state, but has been pretty supportive of psychedelic research in particular. So many of you may have heard of House Bill 1802, which was passed a few years ago. It mandated government funding for a study of psilocybin for treating post-traumatic stress disorder in veterans at a VA hospital. So that study and money actually went to the Baylor College of Medicine and the Houston VA, and that study is actually ongoing at the moment. There's actually another bill that just got introduced, House Bill 3713, that is it's an interesting bill. It's actually designed to try to develop ibogaine into a drug that can be prescribed for various clinical indications. Very unique in that the state would fund drug development efforts in this area to actually get ibogaine to the point of accumulating enough safety data to warrant its capacity to be administered in a clinical trial to humans. And so I think that Texas is unique and actually may be sort of a beacon for how the rest of the U.S. might be able to do this. And it's an interesting process that's occurred here, but there's a lot of sort of bipartisan support for psychedelic drug development, particularly I think because of veterans and because of the fact that they have benefited from this. They've been very outspoken proponents for psychedelics in treating mental health conditions. And then Texas loves to support